Good evening. At the outset, let me thank Dr. Malay Sharma for giving me this opportunity and also for giving me the materials, which because this is not a familiar topic for me. Though I'm not an experienced person in this. Thank you, Malay. So, contrast enhanced EUS is an excellent mode. I will come to that with a few basics and then the clinical application. We know that the B-mode ultrasound is an excellent modality for tissue imaging, but cannot prove any information on tissue perfusion. The color Doppler sonography provides information on tissue perfusion. Lower limit of color Doppler sonography for vessel assessment is 100 micrometer. In contrast enhanced ultrasound imaging, we can improve the lower limit for vessel assessment to 40 micrometer. Even the capillaries, capillaries are at 5 to 10 micrometer in diameter. So the ultrasound contrast agent is made of small air bubbles or microbubbles, which are 1 to 1.7 micrometer in diameter. The small diameter of microbubbles allows them to pass through capillaries of pulmonary and systemic circulation. The microbubbles remain stable as they pass through the capillaries. The microbubbles oscillate like the plucked string of guitar on receiving the ultrasound waves. The echoes from microbubbles increase the backscatter signal of ultrasound waves by up to 30 decibels. In a nutshell, a gas-filled microbubble stabilized against dissolution, irradiated by an ultrasound field, enhanced acoustic backscattering of blood-filled regions. And there are many contrast agents are being used for this, and all these are blood-pool agents. Some contrast agents like Livovist are phagocytized by Kupffer cells or reticuloendothelial cells. The UCA as pool agents have prolonged resistance within the cardiovascular circulation. The UCA consists of gas microbubbles coated with a thin shell. This thin shell is usually composed of lipid molecules or albumin. The gases usually contain heavy gases such as perfluorocarbons or sulfur hexafluoride. The low rate of diffusion of gases and slow dissolution of shell prolongs the life of microbubble from less than a minute to as much as 10 minutes. The gas filling the microbubbles is exhaled via the lungs within 10 to 15 minutes after injection. So the lipid molecules are biodegraded and join the body pool. Now, this is how the microbubbles, this is a picture depiction, 1 to 7 microns in diameter, and the shell is of lipid, and it ranges from, the shell is made of lipid protein or polymer, and the filling gas is nitrogen or perfluorocarbon or sulfur hexafluoride. Now, the difference of contrast imaging between a CT MRI and an ultrasound. In general, the wash-in and wash-out of contrast agent during CT, the iodine and MRI, the gadolinium chelate, both are same as CHI. However, the contrast agent distribution is only examined in a static manner in CT and MRI. We have very few previously defined time points. And in CT and MRI, the first scan, that's the arterial phase, occurs less than 20 seconds after injection. Therefore, the very early contrast wash-in phase is missed. So in CT and MRI, the contrast agent exits the vascular bed immediately after washing, that's extravasation, and are distributed in the extravascular space. So this is a picture. You can see that this right hand up, I don't have the cursor. So this right hand upper picture, you can see that the initial, the fill-in phase is lost here, the initial 10 seconds. Whereas in a EUS, it's not static, it's actually moving. So, and also it is the fill-in, the early fill-in is also imaged here. So the contrast enhanced ultrasound has two phases, that what I was of blood flow for most organs. One is the washing phase, that's what I was telling, the 10 to 30 seconds. The washing refers to a progressive enhancement within the region of interest. From the arrival of microbubbles in the field of view to peak enhancement. That is the washing phase. And the washout phase is 30 to 120 seconds, that is It refers to reduction in enhancement after peak enhancement. So this is how it looks. So you can see that the arrival of the air bubbles in the first picture, and then it increases the peak. Then it slowly fades out. That's the washout phase. The first is the washing phase, and the second is the washout phase. Now, a word about mechanical index. The ultrasound waves flow. It's a form of energy which work on the principle of alara, that's low as reasonably achievable. The safe limits of energy levels were measured by mechanical index and thermal index. The mechanical index is the isolation of power, that's the acoustic pressure of sound wave. Currently, the FDA suggests a mechanical index of 1.9 as the upper limit of diagnostic ultrasound, and they say that's a safe point. The isolation of mechanical index is measured by the ultrasound beam's bioeffect. Refraction can produce cavitation within the tissue. So as the mechanical index increases, it can produce tissue damage, tissue cavitation. So all the ultrasound machines are fixed at the FDA regulation, that's 1.9. We don't have that, we don't want that much of mechanical index. Actually, it's strictly a cavitation index, and that measures the mechanical mechanical damage. So it's an ultrasound metric and unitless number. The user does not actually pay any attention to this parameter during the imaging. For contrast enhanced ultrasound EUS examination, it is essential to pay attention to this parameter. And the MI gives an indication of the likelihood of bubble disruption. So it's very important that you need to keep it at the level of, let's say, thing. The basic principles of tissue harmonic imaging, the ultrasound echoes from native tissue are of two types, linear and non-linear. The linear echoes turn to the transducer with conventional fundamental frequency, whereas the non-linear echoes returning to the transducer consists of signals of harmonic frequency. Imaging of second harmonic frequency is the basis of native tissue harmonic imaging. So tissue harmonic imaging eliminates the linear echoes of fundamental frequency for imaging. And the elimination of fundamental frequency significantly improves the signal to noise ratio of THI. See, here you can see that there are three waves. One is the first harmonics, which is the red color, then the second harmonic, which is the blue color, and the third harmonic, the dotted. So we are only focusing on the second harmonic. The contrast agent microbubbles resonate with harmonic frequencies while adjacent tissues do not resonate. That's very important. And these the frequencies have a decrease in intensity. You can see that as the other frequencies are removed, the second harmonics will be showing very clearly. So the signals of tissue harmonic imaging can come from a moving blood or a stationary tissue. The UCA within the ultrasound contrast agent within the blood vessel enhances the signals of microbubble. So the UCA do not enhance the signals of tissue adjacent to the blood vessel. And the subtraction of tissue signal from the background static tissues can produce a microbubble only or contrast only image. That's important. The rest of the things are subtracted. And the subtraction increases the signal to noise ratio. There are three agents which are available, but I think we have only Sonoview. The rest is a Sonosoid or Definity. And there's no clear difference in the diagnostic ability between the three contrast agents. So how do you set the mechanical index? That should be between, you have to set it between the 0.1 and 0.4. And it should be adjusted as per the type of CEUS, the ultrasound machine, the image processing technology, and focal points. So that's important that in detail, Malay will be telling you during a live session. So the contrast in harmonic EUS should be observed for 120 seconds after injection of the contrast agent. The duration also depends on the target organ. In the pancreas, the signals appear from 10 to 15 seconds after injection and peak at approximately 20 seconds. The phases are identified as arterial phase, that's the early phase, that's the 10 to 30 seconds, and the venous phase, that's the late phase, 30 to 120 seconds. That is the enhancement of splenic vein, portal vein, supramesenteric vein. So in liver and spleen, the observation time includes the sinusoidal phase over 120 seconds and the late washout phase of 240 seconds. Now coming to the clinical application, the basic, I was just mentioning a few points in the basics. And the clinical applications, one is a pancreatic mass, the focal pancreatic mass, the most important thing. And the second is the evaluation of acute and chronic pancreatitis and the pseudotumour formation in chronic pancreatitis. And complications associated with pancreatitis, the assessment of cystic lesions, which is differentiating mucus plugs from small neoplastic nodules, characterization of intraductal biliary or pancreatic filling defects, gallbladder lesion, subepithelial lesions, and lymph node assessment. Now, coming to the focal pancreatic masses, the meta-analysis on CE-EUS, both high and low MI techniques, the sensitivity of 94% and specificity of 89% for the detection of pancreatic ductal adenocarcinoma. So contrast enhanced CE-EUS can differentiate the nature of solid pancreatic lesions. PDAC typically hypo-enhances pancreatic ductal adenocarcinomas, typically enhanced lesions in CE-EUS. Now, this meta-analysis also says that the sensitivity of the pancreatic adenocarcinoma is 89%. That's it is a 2014 meta-analysis, and the specificity is around 84%. The meta-analysis by Gong et al. In 2012, this analyzed CE-EUS for the diagnosis of adenocarcinoma. Again, the pooled sensitivity of 94% and specificity of 89%. Now, contrast harmonic use recommended for characterization of pancreatic solid masses. It is recommended definitely, and it's recommended for the characterization of solid masses. And the hypo-enhancement or heterogeneous enhancement, that is a typical of pancreatic adenocarcinoma. And iso-enhancement is the inflammatory mass, and hyper-enhancement is the neuroendocrine tumor. So the heterogeneous enhancement and hypo-enhancement in a neuroendocrine tumor are predictive of malignancy. So you can see here this pancreatic lesion, which is very hypo-enhanced comparing to the surrounding tissue. So some inside the vessels inside the central anechoic net process. So you can see the FNA being taken from that during a late venous phase. So this focal pancreatic masses for tumors less than 20 millimeter in size. This contrast enhanced use is more accurate than contrast enhanced MDCT due to higher spatial resolution. So in tumors less than 20 millimeter, it's more useful. So it can be used in targeting the EUS FNAC. It increases accuracy from 78% to 87%. Now here you can see that the obstructed branch, the tumor here. This video will show you how it is. The first, you can see this.
Real-time elastography is used to assess the relative stiffness of tumor tissue.
You can see this, the elastography which is showing the hard area. And once the contrast is given, you can see that very hyper-enhanced, hypoechoic mass with the hyper-enhanced wall. It is very typical of pancreatic adenocarcinoma. So, is contrast harmonic EUS recommended for the detection of subtle lesions of pancreas? Yes, it is recommended for detection of subtle pancreatic lesions, especially when they are either small or difficult to detect, as per the Asian Federation Society's ultrasound in medicine and biology guidelines. So, is it recommended for pancreatic cancer staging? Yes, for selected patients with suspected major vessel involvement, it is recommended. Now, for NET, pancreatic NET, EUS is the preferable imaging technique for detection of pancreatic NET, and the sensitivity for preoperative localization of pancreatic NET is 95%, and for MDCT is 81%. So the MDCT, the NET can be discriminated from pancreatic ductal adenocarcinoma by the hypervascularization at the capillary level. The typical features of small NET less than 15 mm is a hypoechogenicity in B mode and hyperenhancement during contrast enhanced CEUS. These are typical characteristics, more than 95% of small pancreatic NETs. You can see here the lesion is hyperenhanced in the arterial phase with washout in the venous phase in here. And here again, we can see this lesion, which was when the contrast is given. You can see the hyper enhancement. Just here you can see that. You can see that very much hypervascular. The pancreatic, typical of pancreatic NET. You can see that. So coming to acute and chronic pancreatitis, the both mass-forming chronic pancreatitis and autoimmune pancreatitis present as hyperenhanced pseudotumours. So pancreatic adenoma has a hyperenhanced lesion, as we have seen. Contrast enhancement can also be used to assess the therapeutic response to in the treatment of autoimmune pancreatitis with limited data. So here you can see this pancreatic pseudotumour. You can see this one, it's very, you can see this. So this is pancreatic pseudotumour, not a pancreatic adenocarcinoma, which is a hypoenhancing. Here it is actually hyperenhancing. Now, in pancreatic cystic lesions, assessment of cyst walls and subtype improved using contrast enhancement. Serous and mucinous cysts were frequently hyperenhanced. Pseudocysts were hypoenhanced in 90% of the cases. So differentiation of solid components within the cyst human is facilitated by contrast enhanced EUS. Now, how to differentiate the mucus clots and debris? They are typically non-enhancing, and hyperenhanced solid structures within the cyst or at its margins may indicate solid neoplastic tissue. The borderline lesions or malignancy. In contrast enhanced EUS, it differentiates neural nodules from mucus clots. The sensitivity is 100% and specificity 80%. It can be used for risk assessment of intraductal papillary neoplasms also. Here you can see a cystic lesion, and once the contrast is given, and there's a small solid nodule there that is actually hyperenhancing, from which it can differentiate that neural nodule very clearly. Coming to gallbladder lesions, it's useful for differentiation between the gallbladder lesions and SLED. Sensitivity is 100%, specificity 99%, accuracy is 99%. So the EUS can criteria is thickened gallbladder wall, visualization of irregular vessels, heterogeneous enhancement of wall structures. Now coming to subepithelial lesions, CE-EUS is useful to discriminate benign SCL from GIST. The GIST will hyperenhance, is a typical feature of GIST. The sensitivity is 85% to 100%, specificity 79% to 100%. While assessing the malignant potential of SCL, irregular intratumoral vessels are predictive of high-grade GIST also. Here the sensitivity varies from 54% to 100% and specificity 63 to 100%. Now coming to lymph node, to determine the nature of the obscure lymphadenopathy, it's actually conflicting. The meta-analysis of CE-EUS assessment of lymphadenopathy, 4 studies, 336 patients, and the pooled analysis show that sensitivity is 82%, specificity 90%, and similar to a diagnostic occurrence of EUS. So the European the guidelines also say that the CE-EUS is recommended in solid pancreatic lesions, clinical staging of pancreatic adenocarcinoma, characterization of pancreatic cystic neoplasm, gallbladder lesions, lymph nodes, GA wall lesions, and assessment of visceral vascular diseases. Now, it is recommended for guidance of EUS primary aspirin. Only in selected cases, such as those with avascular areas or unclear margins, we can take that area. So, do we need contrast agents for EUS? The answer is yes. It offers complementary information over grayscale and elastographic imaging results. It's safe and carries a negligible risk of adverse events. The serious anaphylactic reactions was observed only in 1 in 10,000 patients. It's minimally invasive. It offers a complementary information to BMOD and can be used for characterization, differential diagnosis, and or staging. Thank you. Thank you very much.